conditions masquerading as a disorder of gut-brain interaction that we actually pick up. We always remember that one pancreatic cancer amidst 1,000 disorders of gut-brain interaction. And then we give ourselves a pat in the back for that one case, but for the 999 that we don't manage well, we don't really bat our eyelids on. Right? And then we don't really know how to use pain medications. So if pain is actually one of the biggest problems that we're dealing with, then how come we are so bad at managing pain using medications? We try to cycle them through PPIs, antispasmodics, probiotics, but we don't really know what we're targeting. And so I think that's again one of the areas that we're going to focus on in this session. And one of the very important parts is we always think about the patient in a biomedical sense. So what this means is we want the patients to come in with a very clear diagnosis, very clear treatment plan. Everything is acutely treatable. And the patient's wish is that way, we wish is that way, but oftentimes it's not. When we're dealing with chronic abdominal pain, we're dealing with patients that has multiple issues contributing to the pain. And if we don't think of the patient in a biopsychosocial way, then we will struggle with actually managing the patient. Right. And the focus of my talk today, maybe dominantly on the third point, a bit of the fourth, and I suspect Simon will also speak a lot of the fourth point. So I just want to introduce this to people who have not seen this before. This was published a couple of years back in Lancet Gastro, and it's important that we start to understand how to view IBS. Now, using IBS as a prototype for disorders of gut-brain interaction, and in this paper by Alex Ford and his team, what they propose, as you can see, this is the traditional way that we've understood IBS for a long time. We subtype IBS patients based on their bowel movements. So we treat IBS constipation a certain way, we treat IBS diarrhea a certain way, and pain sometimes gets ignored in this way of thinking because you're focusing on the bowel movements with subtype patients. And over the years, we have improved our understanding of how to treat pain. Right? So this model of understanding IBS is not enough. We should no longer think of IBS patients based on their bowel movements alone. And so what these authors suggest is that we should think about them not just about their bowel movements, but also their abdominal pain together with their extraintestinal symptoms and psychological burden. So you can see where I've drawn the red boxes. It's not just the bowel movements, the diarrhea or the constipation. You can see the box in the top right. Abdominal pain severity, extraintestinal symptoms, psychological burden. These are big parts of subtyping your IBS patients. And why do we do that? Now, if you look at the way they've grouped the clusters of patients in their population studies, they've reproduced 7 clusters, and these clusters are very different, right? You can see the p-values on the right, that each group is significantly different from the rest. So what does this mean in terms of implications to treatment? It means that we don't just treat the bowel movements, which is what we have been very used to in treating IBS patients. We try to treat the constipation, we try and treat the diarrhea, but the pain and the psychological burden tends to get ignored. But if you believe that these clusters are real, then the treatment of what we have been doing all these years will not be satisfactory, especially for the complex IBS patients, especially for the abdominal pain component of their symptoms. So let's just talk about pharmacological management of IBS, and which especially about pain. Now, the last major guideline from North America was published in 2020, and I chose these 2 statements just as a reminder because these 2 drugs are probably the most prescribed medications for IBS. And you can see probiotics, antispasmodics, and the guidelines are against it because of the low evidence. But as mentioned, if you want to try them as your first line, you can do so because their safety profile is good. But likely, you will prepare yourself for disappointment when you're dealing with complex patients. Instead, I've put up here a best practice update from the AGA in 2021, telling us what we ought to do. And I've circled a few of these advice. Right? The first is that we need to talk about non-pharmacological methods. Right? And you can see that here it says non-pharmacological therapy should be considered routinely as part of comprehensive pain management. All right, so that's the first statement I wanted to draw your eyes to. The second statement, as you can see here, that providers, which is us as gastroenterologists, we should be able to understand. We should be able to optimize medical therapies that are known to modulate pain, able to differentiate gastrointestinal pain, visceral factors, centrally mediated factors. So we must understand how to dissect the pain history and figure out what's going on. And the final one here, that we providers have to familiarize ourselves with at least a few effective neuromodulators. We need to know how to use them, the side effects, and we need to know how to explain to the patients what these drugs are. Right? And I'm just going to briefly explain to you why and how these drugs work, because sometimes that's the starting point where we don't understand enough about how these medications work. So as you can see here, the brain and the gut, they communicate via what we call afferent and efferent signaling. So if you look at A, where my red box is, when you distend the gut, the mechanoreceptors will pick this up, and this information is carried by the spinal afferent nerves to the dorsal horn of the spinal cord. Then this sensory input will ascend the dorsal column to the thalamus and various cortical regions, and the brain has an area which we call the salience network. So it's made up of multiple areas, and it detects what is physiological, what is non-physiological, and then it will choose a response to it. Right? So these brain networks, they communicate with other parts of your body, like your autonomic nervous system, your emotional arousal system, which is why pain can be an emotional feeling. It can be associated with memories. It's because these brain networks are connected. So what happens in subsequently in, as you can see in B, the brain will process all this information, and they will activate the autonomic nervous system, the gut and immune function, and it will send what we call descending pain modulatory pathways. Right, you can see there are different nerves coming down from the brain to the gut, and these pathways can actually inhibit and modulate the kind of pain signals that you will actually get from your gut. Right, so changes to your gut can make changes to your brain, and vice versa. And this is one of the foundational principles of understanding the brain-gut axis. Now, the other important thing to know is how these drugs, or what we call antidepressants, how they work and when to anticipate some of the efficacy. So most antidepressant drugs, they work by blocking the presynaptic pump of one of the three main monoamine neurotransmitters. So we're talking about serotonin, noradrenaline, and dopamine, these three. So what happens is once you block the reuptake, what you'll get is that the neurotransmitters will accumulate, and then you get a down regulation on the other side, the postsynaptic receptors. And it's this latter effect that actually account for the antidepressant actions for the drug, which can take 4 to 6 weeks, right? But the ways that these drugs work for pain relief is different from antidepressant relief. And therefore, it tends to work earlier. We're talking about 2 to 4 weeks, right? But this is something that you have to know, and the patient themselves have to know, because when you are giving instructions to patients about compliance to the drug, no one likes to take medications where the side effects happen the next day, but the good effects only happen in a month, especially if no one explains this to them, right? So oftentimes we have to tell the patients that the effects will come in much later on. And also, one of the things that we will have to explain to patients that side effects, even though they happen immediately the next day, sometimes they actually do reduce in 1 to 2 weeks. Also, because of the same concept of the receptor downregulation, your receptors are less activated, and therefore your side effects are also less, right? So again, this is something that we need to tell our patients. This is an overly simplified diagram, but what I want you to appreciate is this. Neuromodulators, they work at different levels. They may interfere at the brain level, like the pain-related brain circuits. It may interfere at the peripheral level, from the pain transmission from the gut into the spinal cord, and it also can interfere with the descending pathways, which I mentioned earlier, right? And again, over the last decade, one of the other interesting mechanisms for neuromodulators is neuroplasticity. So what does this mean? Like if your brain cells, for example, when you subject it to psychological trauma, right, you can actually see changes in parts of your brain, like your hippocampus. And likewise, when you actually treat the patients with neuromodulators, studies have shown that some of the brain-derived neurotrophic factors actually increase, and actually you can almost rewire your central nervous system. And actually, after a certain time of taking these medications, you can take your patients off the medications. So you can see what I've written here in one of the at the side is that you should try to keep your patients on these medications for maybe more than 6 months, sometimes a year. And then once they're stable, you start to taper them off. So they're not on these medications forever. And again, this is something that we have to inform our patients when we actually prescribe these medications to them. So I would like to turn your attention to some evidence. This was published quite recent, and an updated systematic review and meta-analysis by Alex Ford and his team. And just wanted to show you some of the evidence behind these drugs that we use. The best evidence will come from tricyclic antidepressants. There are about 11 trials here. It's about 30% reduction in symptoms. As you can see, the RR is about 0.7. Okay. And so we talked briefly about tricyclic antidepressants. These are very good drugs because they block everything. And because they block everything, the side effects are also quite substantial, right? You block pain that's coming from different pathways. As you can see, because you block multiple pathways, you don't really know for each patient which pathway is contributing to the pain. It could be the noradrenaline, which is the dominant pain pathway for many patients, but serotonin is involved in pain, histamine is involved in pain, right? So which pathways actually help the patient? We're not sure, but tricyclics, they block everything. So it's actually quite a good drug to use. But as you can see here, many times we don't get to the dose that we need. 25 to 50 milligrams of amitriptyline or nortriptyline, that would actually be a good dose to use. But many people are around, they give around 5 to 10 milligrams, and the patients get the side effects, and they kind of withdraw from that, and that they don't really reach the actual efficacy of the medications. They don't know whether the medications truly work. Now, if you want to know what's the difference between amitriptyline and nortriptyline, nortriptyline is less anticholinergic, so you may get away with less side effects for these patients. The efficacy should be similar, but amitriptyline does, because its anticholinergic effects are quite profound, you may want to use that to your advantage when you're dealing with patients with IBS diarrhea, because you want to slow down the gut so that the patients can also improve their pain and their bowel movements. And this is one of the studies that we waited for a long time, because we were keen for people to realize that these are wonderful drugs. So in this study in the Lancet a couple of years ago, the Atlantis trial, this was done in primary care in the UK, where they recruited Rome 4 IBS patients, and they randomly assigned them to low-dose amitriptyline or placebo for 6 months. And interesting enough is they actually let the patients titrate their own doses. And this was done in primary care, so not at a specialist care level. And the IBS symptom severity score, as you can see here, it dropped significantly between the group that was given amitriptyline. And what was interesting is that if you look at the HEDS anxiety and HEDS depression scores, there was no change. So what this tells you is that the effect of tricyclic antidepressants on the patient's symptoms was not mediated by the anxiety or the depression changing, right? It was actually a pain medication that was working as a pain medication. Right. So this was an important concept. And this is the algorithm that was found in the paper, where the patients themselves could titrate. Right. So what this tells us is these are safe medications, because many physicians are very afraid of using medications like these, because they think there's a stigma behind it. They think that these are difficult drugs to use, but that's not true. Right. The doses that we use are far lower than what the psychiatrist uses. And so it's very effective, very safe to use tricyclic antidepressants. How about the other drugs in this systematic review? You can see SSRIs at the top. They may not be as effective as we think. And at the bottom, you can see the alpha-2 delta ligand agents. So these are your pregabalin, your gabapentin. So SSRIs are fantastic anti-anxiety, antidepressant drugs. But for pain relief, they're not great. For drugs like pregabalin, gabapentin, I believe there's not enough studies for them to actually demonstrate the efficacy for conditions that we're dealing with, right? But you can see the signal is there that they do work for our patients. And if you look at two other medications, SNRIs, so your serotonin, norepinephrine reuptake inhibitors, and mirtazapine. And for both of them, for mirtazapine, it looks like it's significant based on this systematic review. But again, for SNRIs, the signal is that it helps, but the studies are limited. Yeah, and so let's talk a bit about SNRIs, okay? So SNRIs are very useful drugs. Again, if your patients respond to tricyclics but they cannot tolerate some of the side effects, like the anticholinergic side effects or the drowsiness or the hypotension, SNRI may be a good alternative. So duloxetine is probably the easiest ones to use. The challenge with venlafaxine is that it blocks serotonin and norepinephrine at different dosing. So when you start low, you're only blocking serotonin mainly. In order to block norepinephrine, you need to get the patients on really high doses, and sometimes that's where all the side effects come in. So duloxetine is actually the ones that I really like using, because it's very easy to use. You can just give 30, 60, and the side effect profile is generally quite good. Maybe nausea is your main side effect, and it tends to go away if you let the patient take the medications with meals. Mirtazapine is also an unusual drug that belongs on a class of its own. Some people call them tetracyclic antidepressants. Again, this is another drug that is very odd in its dosing. So those of us who have used this before will know that at low doses, at 7.5 milligrams, the side effects of drowsiness are worse, right? Because many doctors intuitively will reduce the dose because the patients are too drowsy. But they don't realize from mirtazapine is really unusual that at low doses, the histamine profile, the histamine affinity is higher, and the patients are more symptomatic. And therefore, you want to start them on 15 milligrams or even 22.5 or even 30 milligrams. So mirtazapine is useful because it blocks other receptors like 5-HT3. So it's a mini ondansetron that helps with nausea, right? And it's also anti-histaminic. There's also a 5-HT2C blockade. So all these things help to reduce anxiety. But they also do cause some drowsiness. But one of the benefits of a drug like mirtazapine improves appetite. You know, your patients will gain weight, especially useful for your patients with functional dyspepsia. So this is a nice algorithm that puts everything together. You can see that the choice of drugs depends on what you're trying to treat as your dominant symptom. And sometimes you use the side effects of the drugs to your advantage. But I think what's important is you have to give yourself an interval period to review a response, right? You can't see them in 6 months' time because that's not being fair to the patient, and it's difficult for you to assess the response. So what we often do when we prescribe the medications, we actually give an appointment to see us in about 2 months. So that's when we actually decide of whether the patient's responding or not, because we want to check compliance, we want to check that the drugs are truly working, we want to check the side effects. So I put this red box here, I've drawn it here because psychological therapies, which I believe Simon will cover later on, they are very useful adjunct for chronic pain, but it's not the only thing that we can think about. So I've shown you a few pictures here just so that to whet your appetite. So on the top right, you can see two different medications, iberogast, which is a herbal supplements. There's also a traditional Chinese medicine that we sometimes can find. And these are very useful for functional dyspepsia, for irritable bowel syndrome, and they can tackle mechanisms that the Western medicine are not able to. You can see breathing techniques here. You see acupuncture. And there's also in the middle, you can see a chest biofeedback. So this is something that we also are trying to do in our center with our chest physiotherapy colleagues for patients with abdominal phrenic dyssynergia. These are patients who complain of abdominal distension that gets worse as the day progresses. That's largely because of the diaphragm not moving the way that it's supposed to move. And the treatment is not to give them medications. The treatment is actually to correct the paradoxical movements and actually get them feeling better. And so that's why we work with our chest physiotherapy colleagues. And the success is quite reasonable. And you can see also on the left, I put exercise and I put sleep as part of it because I think we can never ignore some of these contributions to chronic pain. So I put this slide here just to illustrate a few things. Because the question that people have is, when do I introduce psychotherapies? When do I use the medications? When does each one come? So these are three different situations that is illustrated by this paper, and it may advise you a bit of how you would proceed. So if you have, on one hand, the symptomatic patient of where the pain is the dominant symptom, the pain is the dominant problem. And so in this patient, you want to optimize medical therapy first before even considering psychotherapies. This is a large group of patients that my colleagues send me in terms of referrals. Many times, the anxiety is driven by the lack of control of pain. And when you control their pain, everything else tend to settle down, all right? So this is one group of patients. You also have another group of patients where they have a background psychological comorbidity, such as coexisting depression, coexisting anxiety. And this is where you need to work together with your psychiatry colleagues to treat some of these mood disorders well. You can't do this on your own, and you want to work with your psychiatry colleagues. And there's also another group of patients where it's mostly what we call GI-specific anxiety. This is where the symptom is not as bad as the fear or the anxiety behind the symptom. And this is where we actually would offer the patient psychotherapy relatively early, but also in conjunction with controlling their symptoms. So you can see that in these three different situations, you may want to approach a patient in a slightly different manner. And I just want to illustrate a few points, hopefully some of these will also transition to what Simon is sharing. One of the biggest differences in the last 10 years is not the medications that we have, but it's the way that we structure care to our patients. As you can see here, traditional care is what has been happening all the time for many, many years. Multidisciplinary care has changed things, but often what's most ideal is the integrated care model where everyone is together in the same clinic. And this helps patients in many ways. Adherence to treatment, the collective wisdom is often helpful to aid the patient. And the patients themselves know they're not being abandoned when they're seeing the doctor and the psychologist working side by side. And so one of the ways that we have tried to structure our hospital model is something like this. the patients are waiting in an area where they can see the gastroenterologist and the psychologist side by side in a room. It may not always happen on the same day. Sometimes we do try to do this, and our rooms are separated by sliding doors. So we actually share a big room where we can enter each other's clinic space to actually talk to the patient. And there's also a dietitian nearby. But you can see that within reach in the hospital, we do rely on a lot of different individuals to help us manage our patients. The sleep therapists, the acupuncturists, the pelvic floor nurses, they all help us in different ways where we can work with patients with different conditions. And then one of the questions that my colleagues will always ask me is how do I work with a psychologist, right? It's tough for some of our friends who may not work enough with them. But I believe that I should be helping the psychologist and the psychologist should be helping me both ways. It shouldn't be a one-way kind of relationship. So what I've hoped to illustrate in this diagram here is the role of the gastroenterologist. So when we see a patient in clinic, we are the ones who see the patients first. And sometimes we need to train ourselves as well as our next generation of how to identify patients who might benefit from these psychotherapies. And so sometimes we have once we see certain behavior, certain ways of thinking, that should stir some idea in us that perhaps this patient might actually benefit from psychotherapies. But what we need to do next is to lay the groundwork. We need to choose the right patients. We need to lay the groundwork, and then we work with the psychologist. And then when the psychologist sees the patients, they also present information back to us about the predisposing factors, the perpetuating factors, and these factors are very helpful in us tailoring a management plan for our patients, not just using medications, but also with different therapeutic approaches. So some practical advice, when we deal with patients with disorders of gut-brain interaction and we try to use neuromodulators, we must have an elevator pitch, right? Something that we can just bring up and tell the patients within minutes to lay expectations and empower them. Okay, and this is what so as you can see, the 3 E's here: educate, expectations, empower. But how do we practically do this? It's a very unfortunate acronym that I'm using here. It's called dog shit, but it's something that I found very helpful in actually helping. In helping myself to know what to tell patients. So you can see here, the diagnosis is important, and I've written here a positive diagnosis. You don't tell the patient you have IBS because everything else is normal. That's not a positive diagnosis. A positive diagnosis is you have abdominal pain, it's related to your bowel movements, that is irritable bowel syndrome. That is a firm and positive diagnosis, right? And then we talk to the patients briefly about the organ function, what the intestine does, what the stomach does, and what the brain-gut axis is. Then we tell them what has gone wrong. After the infection, perhaps the dysbiosis, something has gone wrong, the way the nerves function has changed. Right? So this is giving the patient a dignified diagnosis instead of doctors giving the patients no clear direction of where their symptoms have brought them to. And then we try to relate what the patient's symptoms are to the actual explanation. So if the patient is telling us that they often are triggered by drinking milk, then we will try to use milk as an example of how lactose drives the symptoms and the pain, right? So the patients can relate to their own symptoms and they understand what exactly is going on. And then we give them a brief explanation of the natural history. Patients are always concerned about cancers, about organ damage, and we tell them that that does not happen with this condition. We tell them the role of limited investigations, right? And why it's not helpful, because the eye can only see what the eye can see, right? What is happening underneath, we can't really investigate with the investigations that we have. And finally, we tell them about our treatment strategy. We tell them who is involved in the treatment, the psychotherapists, the dietitians, and we tell them about these different individuals, and we make a decision together, right? That's co-sharing our decision making. It's not the doctor telling the patient what they need to do, right? So this is one of my last few slides. Earlier, I mentioned that one of the challenges of managing chronic abdominal pain is that we do not think about the patient biopsychosocially, right? And what does this mean, right? Because many times, as you can see in the box that's labeled FGID presentation, we see them there where they present to us with symptoms, but we don't see everything else at the back. The early life adverse events, all the other factors, the culture, the influence of family, all these things we don't take into account. And some of you may have seen the iceberg of ignorance. You've heard about this before, where executives only see a certain percentage of problems when there's so much else going on. And I believe in many of us as physicians, it's the same thing. We are just seeing the problem, but we're not seeing the whole chunk of issues behind the problem that we see. And with that, I just want to show the last slide here, and with this quote, that sometimes you cannot reduce the pain as much as you want to. Neuromodulators are fantastic drugs, but it does not mean that you abandon your patient. You still have to walk the journey with them. You learn how to manage their pain, improve their quality of life, and that itself is being part. That's part is of being a doctor, and also part of practicing the art of medicine, right? So I thank you all for your attention. I'm going to pass the time now back to the chair to continue the session.
Thank you very much, Andrew. Fantastic talk as always. Now I can definitely remember the elevator pitch that you have suggested. I think that's wonderful. Now, so for the next talk, I just want to highlight, why are we doing this session? Just to share that just last year we have published on how significant really is DGBI in Malaysia. Almost 20% of our population in the community, they do manifest DGBI symptoms. And of these patients with DGBI, quite a high proportion of them do also have underlying somatization and also presence of anxiety and depression. We do not exactly know how to deal with this. Definitely neuromodulator is one, but like Andrew say, psychological intervention will also be important. So I'd like to ask Simon to help us through his presentation on what we can do. Simon, the floor is yours.
Hi, Simon. Your mic is not working.
Hello, how's that? Is that working
Fantastic. Yep. All right.
There we go.
Very well.
Well, sorry about that. Well, again, let me thank the chair and for the organising committee for allowing me to speak tonight. It's an absolute pleasure and honour. And thank you, everyone, for being here on a Saturday. So I'm very pleased to be talking about the psychological aspects of gastrointestinal disorders. These are my disclosures. I will continue. All right, so I'm briefly going to talk about a number of things that Andrew really elegantly identified and talked through, and I'll add to his great talk. I'll talk about some of the common concerns that no doubt everyone here is well aware of. I'll talk briefly about the psychopathology across GI conditions, the evidence for the brain-gut axis and psychopathology, and how it relates to that functional overlay. So how the brain-gut axis is clearly relevant for when we think about DGBI, but also how it plays out in organic conditions and the role of psychology. I'll also talk about psychological interventions and what they probably target, and then when to offer psychological therapy. All right. So what are some of the common concerns of individuals living with gastrointestinal conditions? And of course, I'm talking to the choir here. You all know this better than I, that obviously when people are living with a gastrointestinal condition, there's a whole range of concerns that they can have, not only with the symptoms themselves, but the associated consequences. So the course of the condition, disease, the symptoms, whether it's, there's that unknowingness. So they don't know whether they might be fine this week, but maybe not for their holidays next week, etc. There's can be concerns around bowel-related emergencies. There's certainly higher rates of fecal incontinence in GI conditions compared to the general public. And of course, there's also these concerns around the illness status. So I might be good now, but might not later on. How much control can they have over one's illness? How do they manage that? And often the work that we do as psychologists, but also the work by gastroenterologists, general practitioners, nurses, the whole team is about trying to help that individual build a greater ability to manage their condition by promoting their way in which they can control that condition as best they can. There's also that social anxiety of becoming more isolated. So when people have GI-based conditions, it means that they're also more likely to isolate themselves from friends and family. We all know in social situations that if we were all together, there'd likely be a time would be having some nice Yakult or some other nice food, and we'd be together. And because it's a social event, we tend to have, food with those events. But of course, with people who have gastrointestinal conditions, this could be a time of significant anxiety and then lead to avoidance, which then makes them feel more isolated, increasing the risk of mental health related issues. Obviously, there are medication side effects, which Andrew very nicely covered there, in terms of things like tiredness, lethargy, other forms of fatigue, that can play out, which again make people less likely to take medication and cause, difficulties adjusting to living with their condition when they might avoid their medications or change dose without advice. And of course, there are the adjustment issues. So the potential of surgery, one think about inflammatory bowel disease, where that's more likely to occur, and complications associated with the disease condition itself. And so all of these factors influence an individual psychologically. They increase the burden of living with a gastrointestinal condition and in turn increase the risk of developing psychological issues. So let's now talk about the rates of psychopathology in GI-based conditions. So this is a study that I did with my colleague Prahan. It was using the Rome-5 epi data, so around 50,000 individuals from around the world to about 27 different countries. And what I've done here is I've just graphed the rates of psychopathology of caseness for anxiety, depression, all combined. And you can see with the non-GI, so no GI-related conditions, it's less than 10%. But as soon as the individual self-reports or meets the diagnostic criteria for DGBI, those rates increase to 18%. And so again, the celiac disease there came up the highest of 32%. But there's a number of studies that show that these rates also depend upon a number of factors. So, for example, with inflammatory bowel disease, the rates are, somewhere what we've identified here, about 30%. However, in active disease, it's much higher. It's usually double that, about 66%. And so depending upon where an individual is in terms of whether it's active or in remission, can have obviously an impact on terms of the presentation of anxiety and depression. We also see similar rates in terms of somatic-based symptoms as well. So now I want to briefly talk about two studies that I think are really important to understand and really help us understand the bidirectional process that's linked to the brain, associated with the brain-gut axis. Because there's often that question about, is it psychopathology that promotes GI conditions, or GI conditions promote psychopathology? And really, it's both of those. And this is probably one of my favorite studies by Nick Talley and colleagues done in Australia. And it's a 12-year longitudinal prospective population-based study. And what they did was they had a really large sample of 1,000 Australians, and they looked at this population at the baseline. And what they identified is the individuals had, for example, IBS. There was also functional dyspepsia, but we'll just focus on IBS now. So with one group, they had IBS, but there was no anxiety and depression. So there was no sense that they met criteria for anxiety and depression. But then 12 years later, that group was statistically found to more likely present with IBS with anxiety and depression. So that provides evidence for this relationship between the gut symptoms then promoting psychological symptoms. But there's also evidence for the opposite of that. So in their study, they also had a group that did not have IBS-related symptoms, but they did experience anxiety and depression. And then after 12 years, the results again showed that there was this evidence for the brain-gut relationship, in that there was individuals who have IBS were also more likely to have that comorbid anxiety and depression. So again, this is a really nice study that shows this link over time for the brain-gut axis. The next study is one that my very dear colleague, Antonio Mikawaris, who's very well established, and he was the first GI psych in Australia. And this is a study that's based upon the Swiss cohort, which is a very large longitudinal data set that's been collected. It's now been going on for over, I think it's 15 years now. But this data set here was based upon a 9-year period, and it's for individuals that had inflammatory bowel disease, and so a large sample of just under 3,000 individuals. And the thing that is the most important point that the authors identified was the finding that symptoms of depression and anxiety were the most influential in predicting flare-ups in inflammatory bowel disease. So what this is saying is that poorer mental health leads to poorer IBD outcomes. So it wasn't changed in medications, it wasn't changed in other disease-related factors. What was the clear predictor over time across multiple time points was that if there was a flare-up in mental health symptoms, that was in turn a predictor of flare-up of IBD outcomes. I think this study is important, again, because it provides that link. I don't think it suggests necessarily that there's an underlying biological process of anxiety and depression. For me, one of the things that it probably suggests more so is that when someone is experiencing anxiety and depression, as you know, they're less likely to exercise, they're less likely to eat well, they're less likely to look after themselves, which means that then in turn potentially causes a risk factor for inflammatory processes to occur. But both of these studies provide good evidence for the impact of psychological processes on physiological functions associated with GI conditions. So now, I just in the last slide talked about inflammatory bowel disease, and we know that around 35% of individuals who have inflammatory bowel disease also have a functional overlay. And again, we can see this with other GI conditions that might involve structural issues, inflammatory conditions, or post-surgical disease, whereby individuals will report persistent symptoms of pain, which Andrew identified very nicely in the previous slide as being a very common one, urgency, bloating, and other related symptoms. And these symptoms are out of proportion to those objective disease activity measures, whatever they might be. And so these reflect this functional overlay. And again, underpinning this is this dysfunction between the brain-gut axis, this dysregulation. So what helps explain these mechanisms? Well, I think there's really 4 things that are important to consider. And the first is around that hypervigilance. People become hyper-aware of those internal body sensations, amplifying that symptom perception. No doubt you've had patients that have come in and they'll tell you that they're tracking where food is being processed. They point to it and they can show you where it was. There's sort of the hypersensitivity around that. Now, whether that's accurate or not, they still have this perception around that. And of course, when people experience pain or other unwanted symptoms, that they will focus in on them because they are a threat, and therefore they have to focus on it. They worry about it, which then increases this hypervigilance. And again, that results in this response of these overactive symptoms. There's also this maladaptive threat learning. As I mentioned before, there's this fear conditioning. Experience pain, it might come back. So they're focused in that. And you see this classically with inflammatory bowel disease, where people have had a resection and that it's resolved, and yet people experience pain because they're experiencing anxiety, which causes tension on the scar, and they think, that's where my disease is coming back, because that's where the surgery was. And again, there's that worry that can occur, that hypervigilance. And then there's this altered descending modulation, where there's this impaired brain mechanism that relating to this regulation around the visceral pain and discomfort. And again, some of the things that Andrew talked about around the medications are actually targeting that aspect there. But nonetheless, again, this is an area in which psychology also plays an important role. And of course, there's this autonomic imbalance, this dysregulation. So when people are stressed, when people are anxious, when people are distressed, it's that overactivation of that flight, fight response, that sympathetic nervous system activity. And of course, again, that promotes that hypervigilance, that anxiety cycle. So it becomes this maladaptive cycle that continues to occur. And so being aware of that cycle is obviously important to understand so that it can then be addressed. So it's these four factors that ultimately amplify symptom perception and ultimately the disability. And they promote the ongoing presentation of symptoms, exacerbation of symptoms, and ultimately reinforce the hypervigilance, the attentional bias, that maladaptive threat appraisal, and in turn ultimately leading to both rumination and avoidance. And both of these two things, rumination and avoidance, ultimately perpetuate the anxiety response and also likely the underlying functional symptoms that are occurring. So this is a paper by Laura Kiefer and colleagues, which really tries to, I think Andrew actually presented this one as well, which is what psychological interventions are appropriate for GI conditions. And so really the main ones we might think about is for irritable bowel syndrome and functional conditions like functional dyspepsia. Cognitive behavioral therapy and gut-directed hypnotherapy are probably the ones that from a psychological perspective, the first line, but also mindfulness-based stress reduction can also be relevant. And depending upon the presentation and the nature of the way in which the person is motivated, their insight will influence the way in which psychologists will go about working with individuals. But clearly working on the stress-related process is important, but then adding to that by using things like gut-directed hypnotherapy, cognitive behavioral therapy, or other approaches such as psychodynamic-based processes can also be helpful. And this is relevant for not only DGBI, but of course also for other GI-based presentations. So what is the evidence base in terms of psychological interventions in GI conditions? Well, this is a brief summary here. Essentially, we know that, again, for DGBI, but particularly IBS and functional dyspepsia, where the evidence really has come from, there's sort of medium to large effect sizes for the efficacy for both CBT and gut-directed hypnotherapy. I don't necessarily think one is better than the other. It really depends on the client presentation, and there is no evidence to suggest that one is better than the other at this point in time. Mindfulness-based interventions like mindfulness-based stress reduction is also a good intervention, and there's been evidence both in non-GI conditions for the management of pain, because that was where it was originally established, but there's also good evidence in IBS and inflammatory bowel disease as well. Another, what's called transdiagnostic intervention, so intervention that doesn't necessarily have to result in individual having a particular form of anxiety or particular form of depression, is acceptance commitment therapy. And it's also been shown to be efficacious, not only in irritable bowel syndrome, but also in IBD as well. And there's growing research in ACT in a form of interventions. There is some evidence for psychodynamic-based therapy, but really, by and large, the evidence is around those that are associated with CBT and gut-directed hypnotherapy. Interestingly, both of these, whether it be individual or in group or online or face-to-face, show good efficacy. So again, there is a number of options by which people can access and use these interventions. So what I'd like to briefly comment now on is really when to offer psychological therapy. Well, I think what was really nicely identified by Andrew was that what you saw was that the gastroenterologist was right next to the psychologist. And it's one of the things that's so empowering is when the gastroenterologist introduces, let me just go and get my colleague, and introduces a psychologist and talks about, again, the way in which psychology plays an important role, just like other therapeutic approaches, in terms of working with individuals to improve outcomes. So it's about introducing it early and proactively. It's about focusing on this mismatch between symptoms versus potentially organic presentation. When there's high related hypervigilance, high anxiety, catastrophizing, that ruminative-based process playing out, and significant avoidance. These are all important markers of when psychologists can and should be involved and are likely to have good outcomes based upon the research. Obviously, there are other factors as well. Might be helping with nausea-based symptoms. Think about cyclic vomiting syndrome as an example of that. Sleep-based disturbances. These are also things that areas in which psychologists can help. And of course, just illness-related adjustment. Having someone to be able to talk through that when it might be difficult, depending upon potential family or cultural factors, having that environment to be able to feel heard and understood and validated with their experiences is important to recognise. I'm just going to do a slight plug here. For those who are interested, feel free to have a look at my Mind Over Gut websites. There is an online free intervention for GI conditions. It's not GI specific. Unfortunately, it's only based on, it's only English speaking, but if I can be of any help, please feel free to reach out. I'm very happy to help in any way I can. Thank you very much for your presentation. My contact details are there. Thank you so much.
Thank you, and thank you, Simon, for the wonderful talk. Really, it does give us a introductory perspective to what psychological therapy can do in GI conditions, including DGBI and also IBD. I'm sure this will interest Ida. I can see Ida is also in the group. Now, we do have a couple of minutes just before the lucky draw. Just allow me to ask some questions to our two esteemed speakers. There is one question being posted in the chat. Maybe I'd like to highlight this case. So this question is from Nabila, and she just want to ask some opinion regarding one of the patient with IBS-D, and she has a predominant abdominal pain. She has refractory symptoms, particular pain, despite being on multiple neuromodulators. And the patient also has undergone sessions of CBT with a background diagnosis of depression. Despite that, the patient still require monthly admission for severe pain. And it seems like the trigger, according to what mentioned in the chat, is emotional disturbance. Maybe we can ask both. Should we start with, say, Andrew? I mean, what's your thought about the neuromodulators that this patient was on? Were there enough, too many, too little? What are your thoughts?
Okay, so thanks, Nabila, for the question. So a few of my thoughts about this. I think the first is in terms of the medications, we really have to optimize the dose that we are using. We need to make sure that the patient has taken it long enough for us to know whether it did work or not work. Because if your patient is on, for example, amitriptyline 10 milligrams, and the patient is taken it for maybe 1 or 2 weeks and it doesn't work, that does not mean that the medications did not work. I would actually aim to get it to a dose that I'm relatively sure it will have started to work. So maybe at 25, maybe a 50, right? And if that doesn't work, I will also not change agent. I would actually try to augment it with a different receptor. So for example, I use antipsychotics a lot. So olanzapine, quetiapine, again, not in the same doses that the psychiatrists use, but I use it as an adjunct to pain. I use a lot of pregabalin, gabapentin. Those are peripheral agents. So I think you have to really try your best to hit hard at the pain as far as possible. So that's the first point. The second point is never underestimate the power of lifestyle changes. When I'm talking about exercise and sleep, these in itself do not work, but in conjunction with what you're doing, they make a huge difference. Patients with poor sleep, if you don't correct the sleep issues, they actually struggle with the pain longer than others. And so we take a very detailed sleep history, and we work together with our sleep psychologists to try and correct the patient's sleep issues with CBTI, which is a CBT for insomnia, rather than giving them sleeping medications, right? The other thing is, do check for patients who have pain syndrome. So these are patients with migraines, lower back pain, pelvic pain. Oftentimes, the pain problems, they all bleed into one another. So if someone whose abdominal pain is improving, but they're struggling with neck issues, the other pain issue will actually augment the separate pain issue. So you have to help the patient seek multiple pain relief from. So you may have to work with your orthopedic colleagues, your pain management colleagues, because sometimes the pain is not just in one side; it's in multiple sides. Right. So I would do that, and I will leave Simon to discuss about the psychotherapies, but the adjuncts, I will also try my best. So complementary therapies, acupuncture, I have a very low threshold to actually get these involved in the patient. So I'll throw everything at the patient if I feel that the patient is struggling with the pain, and I've tried my best in terms of medications. Yeah. So I that's my input for this case.
Thanks, Andrew. Simon, what do you think about this case?
Yeah. I think, well, the first thing is, in some ways, this isn't necessarily uncommon, isn't it, really? I think people will tend to present with that ongoing history of symptoms, and they've tried a few things and it's not quite working. So, obviously there's a few questions that I would be thinking about, so what's the background in terms of the history? So do we have someone that has the experience of depression? What's the nature of that? There's often comorbid anxiety in 70% of cases. So is that playing out or is it not? What are the potential causes of the depression? What's the things like childhood history of experiences? How is the family understood? Like, one of the things that I think is really important to understand is, especially when we've got these sort of complex cases, is trying to understand what did they learn as a child in terms of how did the family handle illness? Was it something that we talk about, something that we avoid? How was it managed, and how does that potentially play out now? So that's one of the things I'd be thinking about, is that when we've got this complex case, what is the background that might be playing out, which might be things that perpetuate the presenting symptoms. The other thing I'd be really interested in knowing is, for example, in relation to the pain, when, like Andrew said, really getting to understand about the pain. So when does it occur? When is it more likely to occur? When is it higher? When is it lower? But also, when is the pain lower than one would expect? So when, for example, when is it better when they thought actually they'd be doing worse? What are the exceptions? What does that tell us? Maybe they went, like Andrew said, maybe they've gone for a walk. Maybe they had a good sleep the night before. But trying to understand the exceptions to when they think their pain would be worse, but they're actually coped better or felt that they were able to manage their pain better. What was about that? So for me, that's often really important, because it can tie into them recognizing that, well, actually, I got sleep last night. That was helpful. Or it could be that I talked to my partner. So I think looking for exceptions is really one of the things that I'd be thinking about, along with that background history. Yeah. And understanding that the pain experience.
Yeah, sure. I think there's obviously a lot more detail that we need to get from the patient. But then, yeah, I think those are some of the points that Simon and Andrew have highlighted, hopefully would have helped Nabila in her patient. Now, in the interest of time, I think we need to move on. The next session would be lucky draw. I'll probably pass it back to Joash or Hizami to do this.
Hi everyone. So Yakut has kindly agreed to sponsor us with some lucky draw. So for those who are participating, here's a chance for lucky draw. Hizami, if you're ready.
Yeah. Hi. So yeah, this is the first time that we are doing this. So we have a lucky draw. So we have about 30 plus participants today, and we have 10 spots. So you have a pretty good chance of winning the prize. So let me share the screens. Okay, so this is the wheel of names. So I've taken the liberty to list down all the names of the participants. So let's see who wins.
Drum roll.
Jack. Okay.
Wow, Jack! Oh, yeah. Yeah, Jack is here.
Yeah. So 9 more spots. 9 more spots. Dr. Wanza.
Wow, Dr. Wanza. Drum roll. Pooh, Dr. Koo.
Dr. Koo.
Yeah, he's here.
Okay.
Yeah, I saw him.
So we have
He's
7 more spots. Dr. Chan.
Yeah, Agwan is here also. Yep.
6 more. Dr. Kang. Okay.
Okay.
5 more spots.
Yeah, Kang Ming is here. Yeah, I saw him also.
Hmm.
Wow.
Wei Chin.
Wow, husband and wife. Who you? Nice.
4 more.
Your kids will have a lot of Yakult to drink, I think.
Dr. Hari, you winning one as well.
Yo. Nice.
Wang Chan. Okay.
Yeah, Wing
2
Chan.
more. Liu.
Is Lu Chin Huang
It's
here?
the last chance.
Lu Chin Huang. Is Lu Chin Huang here?
Prof Ida, you won one as well.
Oh, Prof Ida, congratulations, Prof. Thank you for your support.
Yeah. I have no control over the wheel, so this is purely by random chances. So what I will do is I will share the links for the winners in the chat box. So you just fill in the your details, and Yakult will kindly send the prizes to you. Okay, back to you.
Well done, Hizami and Joash, and everyone else who won the first round of lucky draw. I understand there will be another second round, right?
We decided
No,
to do
this is the
all this
only
time.
one.
Kali whack all 10.
Oh, okay.
Uh,
All right. So yeah, thank you to Yakult for sponsoring this, and I know that Izudin also is in the group itself. So thank you, Izudin. Now let's go on to our next session. There will be 2 cases presented, and allow me to invite Joash for the first case.
Thank you, Prof Lee, for this opportunity. And hello, everyone. Hello, friends. Thank you for joining us and supporting us in our very first ever virtual gut-brain MDT. And what I'd like to share today is a patient of mine that I'm looking after by the name of Miss M. She's 26 years old and she has underlying prolapsed intervertebral disc confirmed by MRI spine under the spinal team, and she's on regular physiotherapy for the PID pain. She also has tension type headache, which she has experienced since she was 14 years old. Fortunately, no organic lesions were found on CT scans, and she has been under our our neurology clinic. She is a very bright young lady. She is a qualified university student, and instead of taking a job with her peers and her friends in a big city center, she decided to come back to Alostar, which is where I'm based at, a small quiet suburban town, to continue her father's business in a printing business. So her first point of reference to the gastro services was back in 2024 when she was 24 years old. And at that point of time, she was referred for dyspepsia. But on further history taking, we found out that it wasn't actually just dyspepsia per se. It was more colicky abdominal pain, generalized almost at the umbilical lower abdomen region, associated with constipation, ongoing for the last 1 year. And she finds some relief, or at least it is related with her bowel motion. And because she was initially, the earlier teams were considering a component of dyspepsia, upper GI symptoms, she was initiated on pantoprazole and also etopride to no significant improvement. The biochemical workup was normal, she had no red flags, and the clinical examination was really unremarkable. So because of the long-standing history and because there was no response or no significant improvement with trials or treatment, we initiated her, or we subjected, she was agreeable to undergo endoscopy investigation. We did the upper scope, the esophageal showed that she had a hiatus hernia. She also had reflux esophagitis of grade B, and she did appear, and on endoscopy, there was a thought and a comment that perhaps there could be reduced esophageal peristalsis, whereas the colonoscopy was unremarkable. It was a good bowel prep scope, and it was found normal. So with that in mind, we diagnosed her as, we treated and managed her with two issues in mind. First was being IBS-C, and the second issue was GERD. So we started her on PPI therapy. She was also on prokinetics, and then she was on laxatives, composing of a lactulose and also a bisacodyl. Now, over that period of time from 2024 to, let's say, around December of 2025, she was having 4 to 6 monthly appointments. And it appeared to be a very, very stable, a very happy, a very unremarkable, uneventful follow-up appointments for her in the clinic. In documentation, when I was reading back on the documentation, everything was well. It was described as symptoms were improving with treatment. And at one point in time, we offered her manometry because of the thoughts of that, whether or not was there esophageal peristalsis, there was hiatus hernia. Would manometry give us more answers? But she politely declined because she was working on expanding her father's business. She at some point of time, she was already even taking as per required doses of PPI, her lactulose, and she even stopped her bisacodyl entirely. So when I met her in December, when I first met her in December, she was wonderful. She was pleasant. She was cheerful, telling me about her businesses. And I was this close to giving her an appointment in 6 months because she was really well. And then I so happened I was doing a little study and I decided to give her a questionnaire. By the way, could you help me to fill up this questionnaire, please? And then I gave her the SAGIS questionnaire, which is the Australian questionnaire for structured assessment of GI symptoms, a 30-question questionnaire based on the Likert score, looking at all sorts of symptoms and based on the severity of it. And lo and behold, SAGIS score came out to be very, very high. There was very, very high scores. And if you always look over here, and you look over at the right-hand corner, this is the SAGIS questionnaire, which I translated into Malay. And you see that there are so many questions which she scored, and which she scored at the levels of severe, if not moderate. And she was so worried about the pain affecting her daily life, affecting her. And she was, at one point in time, she was worried that she may even need to be admitted for her pain. So I called her back in and said, no, you're not okay. Come back in. Let's come back to the clinic. Let's talk. Let's have a chat. And then I found out that she was actually going through a lot of challenges at work. Remember that this is a young lady who is a fresh graduate, who is very motivated, very keen to expand her father's business. And she was having poor sleep. She was having long hours in the office. She was putting a lot of pressure on her to meet expectations from her clients. And one of the things that she attributed to is that, yeah, doc, I've been missing my medication. I haven't been taking my medication as faithfully, as regularly as I wanted to. So I had a long chat with her. This is a very bright young lady. I had a long chat with her, told her, look, these are the things that we are going to do for her. I hear you. I believe in your symptoms. Would you like to try something else? Would you like to meet some of my colleagues, my friends in psychiatry team that can help you to navigate your emotions, to navigate your stresses, and even perhaps help with your pain? She declined at this point of time. And she said, I'll try and sort myself up. Give me some time. I'll take my medicine on time. And I decided to see her back in 1 month's time. And I'm glad I gave her an appointment in 1 month, because when she came in this time in January with her mother, she broke down in tears. And upfront, she said, I'm not okay. Things are not okay. It's been hard for me on two aspects. The first is her GI symptoms. Her constipation went into a period of very, very severe constipation where she was feeling very backed up. She was feeling very bloated. She was having pain. And on the second aspect, which she spent even more time talking about, was when she was sharing with me about her stresses. She was very envious with her friends. She met up with her friends a couple of weeks before my clinic appointment. She met her friends. They were in Big Fours, they were in the Big Four firms, and they were doing very well. They were progressing through the career ladder. And she looked at what she had in her bowl, and she realized that, hey, I'm not doing very well. I'm not progressing. I'm not expanding it as I want. And to make matters worse, she felt very unsupported by her brothers who were also working with her. She made an investment in a new printer, and that didn't quite materialize the way she wanted to. She was in a bad shape. She wasn't happy. She was in tears. I promptly referred her to my psychiatry colleagues. They provided her with psychological first aid, and she was commenced on escitalopram because at that point of time when they assessed her, anxiety was high on the score, and anxiety was a predominant issue for her. And we also engage with occupational therapists. In Malaysia, or at least in my center, occupational therapists play a very central, very important role in helping our patients to navigate with their stresses. And I'm so glad that our psychiatry services and our occupational therapy services have started to join me on board with the care of this young lady. Because subsequently, when I saw her 2 weekly and 2 and 4 weekly, there was less tears. There was more smiles. When our occupational therapy saw her, they assessed her based on the DAS-21 score. And although the score was very high, there was anxiety and there was stressor components, but yet they were very focused, they were very determined. She was started on CBT. They engaged her on CBT. She was taught on daily mindfulness practices, and she started journaling. All this while she was continued an escitalopram. But her symptoms didn't substantially improve. When I repeated the SAGIS questionnaire, the scores remained very, very high, and the domains that were affected were similar. It is at the IBS-C domain and the pain domain. And yet, when I met her, when I had that long conversation with her again, something shifted. She admitted and she recognized, and there was insight that I know I'm not there yet. I know I'm not okay. I'm not stable yet. But it feels like something is lifted. It feels that I'm getting somewhere. It feels like I'm making progress. And importantly, she said that she felt that she was coping a little bit better. So what type of medication did I make changes to? I started her on mebivarin. I continued her etopride. I made no changes to escitalopram, and I asked her if she was able to purchase prucalopride, because in my center, we do not have prucalopride. So, but if our patients are agreeable to purchase for it, then I prepare a prescription for them. The last time I saw her was a week ago, and she says that she feels happier. In terms of her entire journey, she finds that, yeah, she is starting to see the light. She's making progress. She feels that she's really working on herself. Work still remains the same. It's still challenging. Her brothers are still a little bit ridiculous, but she finds more joy. She finds more satisfaction. And her new printer is already working better. She sleeps better. She couldn't buy the prucalopride anymore. She stopped taking the prucalopride after 2 weeks. And when I explored, was it a pain issue? Was it that her constipation didn't actually get better? She denied that. She said it wasn't pain. It wasn't because she wasn't passing motion. She did pass motion even better after the prucalopride. But she felt that the 200 ringgit, which is equivalent to, I think, 60 or 50 Australian dollars, the 200 ringgit did put a little bit of strain on her, and she really wanted to put the money somewhere else. She even stopped taking her lactulose and her bisacodyl. In terms of the bowel motion frequency, it was still 2 to 3 days once, a Bristol stool of 3 to 4. And in her own words, the reason I stop it is because I want to be free from so many medication. I've been taking a lot of medicine. I really want to be free from it. I took a long pause. I told her, I'm not sure if we are ready for it. I think we still have room to continue with the medication. Had a long chat with her, psychoeducation and gave her a lot of reassurance on the safety of this medication that she is on. She's very adamant. She didn't want to continue the laxatives. And so in the end, the medication was shrink down to etopride, mebivarin, and escitalopram. So this is in short, this is the journey of my patient that I'm looking after. A young, very bright, very determined, very focused young lady who is struggling with pain, who's struggling with IBS-C. And I'm going to see her next week. I'm going to see her next Tuesday. And really, the question for my panel of experts here is, what are the questions? What should I do next? What are the questions that I miss? What are the questions that I should ask? And what else can I offer her? In working together with my OT, my occupational therapist, and my psychiatry colleagues, what can I do better to help her gain better control of her symptoms? Thank you.
Right, thank you, Joash. So probably let's hear from Andrew and Simon. How about Andrew first? What do you think about the neuromodulators? Is it enough, or what else do you think can benefit this patient?
Okay, thanks, Joash, for presenting. So actually, her medications haven't really targeted pain significantly.
Yeah.
Escitalopram is not a very good pain medicine. The dose of escitalopram is very low also.
Yep.
So I'm not even sure what is actually treating. It may not be treating anything because 5 milligrams is a very low dose, even if you're talking about anti-anxiety or antidepressant dose. And it definitely has very minimal use for pain. And so I think for this patient, a few of my thoughts. She hang the sleep issue in front of you. I think you have to grab it,
Okay.
because for someone like this where they're busy, the sleep is going to be a big issue, and it's very common for people who are struggling with sleep to complain of nausea, and they also have bowel movement problems like constipation. So I think that is one thing that you can work on. It may actually do a lot of changes to her actual control of symptoms. Then, secondly, you want to talk to your psychiatrist colleagues to choose an antidepressant that actually targets pain as well. Whether you want to think about duloxetine, mirtazapine, tricyclic, all of them may make your constipation worse, except duloxetine. Mirtazapine and tricyclics may make your constipation worse. But I think many people always oversimplify patients with IBS-C and say that if I improve the bowel movements, the pain will get better. But sometimes they are not the same mechanism driving it. You need to target the bowel movements and the pain. For someone like her who's young, I'll be very careful to put her on laxatives, because they are usually quite resistant to laxatives for all these young patients, because especially they're working, they don't want to be carrying pills around. So a lot of times, I would try my best to minimize the number of medications that they have. Something like getting into a routine of using Folex, or like Macrogol in the morning, and actually learning how to have good toileting habits may actually do more good for her. If she's someone who's waking up early and then rushing around, she doesn't really have good habits. She sounds like she's that kind of person, is it? So I think there are many of the lifestyle factors can still be worked on. The medications can be, you can choose those medications I mentioned. I think targeting pain. In terms of, because I think for her also, she seemed to, you don't really know whether she's getting better or worse, because I don't know how forthcoming she is with her symptoms. It sounded like she was receiving some help in terms of counseling, in terms of CBT, but I think you need to not forget the biological part. She has some kind of issue that is not addressed biologically, whether in terms of the bloating and the pain. So I would not oversimplify it to say that if I give her psychotherapies, her other symptoms will improve, because there are gastroenterologists who think that way as well. Right? But that's not true. Sometimes you need to do it concurrently most of the time. Yeah.
Okay. Understood.
Yeah, thanks, Andrew. Simon, what are your thoughts?
Well, the first thing I thought was just how well you have been connected to this patient. So one of the things is that you asked them to complete a questionnaire and went, hang on, this isn't right, come in. And then they came in and said, look, these are actually what's going on. And I think what was the next thing I thought was really good was the next appointment wasn't, I'll see you in 3 months' time. It's like, I'll see you next month. And because they really weren't, they were, you have to sometimes let the patient get to a point where go, actually, I do have a problem and I'm ready now to resolve it. Whereas she was still in the, I've just come, I've done my training, I've done my degree, I'm going to make big changes to the family business. So there's no doubt pressures there, potentially from the man, but really it sounds like from her. So a real sort of, I just get a sense of like classic IBS, which is around, young, female, highly intelligent, highly driven, perfectionistic. They're like triggers for these sort of psychological presentations in this cohort. And so again, allowing her to have that space to be able to go, actually, I'm not doing well, and develop that insight to then allow you to work with her. I think that was really good. I mean, Andrew touched on sleep. I think I agree. And the other thing I'm mindful of is, well, there has been times where she has done better. And so, well, why? What have you been doing? Like, it always come back to those exceptions when things have been going just a little bit better. Well, what are the things that you've been doing? Was it that you really focused on getting a sleep routine, sleep hygiene processes, or was it that you were able to talk to the psychologist or talk to friends? Like, what was it that helped them to feel more in control of the challenges that we're facing, and where they're able to manage their pain even just a little bit better?
Understood.
Because knowing that, clearly, as Andrew was saying, there's the biological component of the symptoms, but overlapping is this hypervigilance. And she has been working with it sounds like with a psychologist. And so don't exactly, doing CBT, which is entirely appropriate, but whether something like an overlay of hypnosis, so would be a potential option as well, or mindfulness-based stress reduction. It depends on her personality as well. She might be interested in yoga, so that's where I'd go into. So building up one of the things where she's building her esteem, building her a sense of being able to manage the condition, and using those things that she's passionate about to try to help move in this space. That's a brief summary anyway.
All right. Okay. Thank you. Thank you.
Yeah, thank you, Andrew. I'm very mindful of time. So I hope from what our two experts have provided, that should give you some idea on what to do next. I hope, Joash. Now, can we have the second case? This will be delivered by Dr. Hizami.
Hope you all can see my screen.
Yeah, it's coming. Yes.
Okay. All right. Okay. Thanks Prof Simon, Prof Andrew, for gracing the event. So I'm going to talk about a case that we saw and still under our follow-up recently in USM. Quite an interesting case. So we have a 30-year-old lady who has been complaining of recurrent colicky and burning abdominal pain with loose stools for the past 2 to 3 years actually. But the main concern for her is the pain rather than diarrhea. So the baseline pain score was around 3 to 4 out of 10, but it may worsen up to 9 to 10 out of 10, which will require admission on and off, which is quite frequent at times. And it's usually at the lower abdominal region, no obvious identifiable triggers with any specific group intakes, no bloatings. There is some sleep disturbances due to the pain, but it has been worsening over the past 3 years. And all this started after a laparoscopic emphysectomy for an appendicitis, which is uncomplicated, very short stay in the hospital, 3 days and then discharge. Unfortunately, she will have this recurrent hospital admission. She'll be admitted 2 to 3 times in a year for very bad abdominal pain, which will require analgesia. She is previously at a public hospital follow-up before recently decided to come to us for a second opinion. And she's been taking multiple different type of analgesias just to control the pain. So she is allergic to a lot of medications and she will develop urticaria and itchiness because of this. She works as a wedding or event planner. No significant major life events happening in the past few years. Her anxiety score was quite low. The only thing is she stopped taking new jobs because of the pain. And at the same time, she's been having this chronic headache, which was investigated by the neurologist. It was mainly right-sided, happening almost every day. No photophobia, no obvious relationship with the abdominal pain. The CT was done, which actually shows vascular loop type 2. The beta blockers doesn't work. The typical migraine medication doesn't work. The only thing that works for her is NSAIDs, which is Arcoxia and Celebrex. So the interesting part is she presented to us in a rather interesting way. Her first contact was in December 2025. She was actually referred to us for a hydrogen breath test because we suspect that it might be SIBO. So, she came to us, she took fructose, and after that, she immediately had a very, very bad abdominal pain. So it's quite dramatic. She was screaming. What happened is from our lab, she has to go to emergency department, receive fentanyl, and then she developed urticaria after that. That's when we know that she actually is allergic to fentanyl, and then subsequently was discharged with NSAIDs after a period of few days. So unfortunately, she was admitted again. So it was a very frequent admission over the past few months. So at the end of December until early January 2026, she was admitted again for worsening abdominal pain with pain score of 9 out of 10. We actually had to consult our acute pain service. She required IV morphine and had to start on oral hydrocodone and then discharge again once the pain score came down to 3 to 4 out of 10. So she unfortunately was not really, the gastro wasn't really consulted to us during this time. So she was actually discharged with PPIs, Ganatons, Oxynoms, antispasmodic agents and probiotics, and some low FODMAP diet advice was also given. Again, at the end of January, she was admitted for another episode of severe abdominal pain. with worsening diarrhea 6 to 7 times per day. Another APS consult was done, started on syrup morphine this time. No improvement despite attempt to adhere to low FODMAP diet. At this time, we actually started on we started the patient on some kind of neuromodulator. So we started her on amitriptyline and pregabalin. True enough, immediately 2 or 3 days after that, she started developing a very bad drowsiness. But we told her to kind of persist and hopefully it will work later on. We tried to empirically treat her with rifaximin 550 milligram for possible SIBO because obviously she is not very keen to do another hydrogen breath test. Unfortunately, she developed severe headache after 2 doses. So everybody was blaming rifaximin after that, although the chances for that are low. We actually did a CT which does not show anything, but she's not keen for another trial of rifaximin, so we didn't pursue this course further. So she was discharged. So in early March, again, she was admitted for another episode of severe abdominal pain. Again, another acute pain service consult was done. She received IV morphine. But at this time, they actually try and do a transabdominal plane block, hoping that it will improve, but unfortunately it doesn't. So what we did is, first of all, I tried to increase the amitriptyline to 25 milligram BD, but she was very, very drowsy the next day. So what, as a compromise, I actually cut down the night dose to 15 milligram once daily. But we do add on agomelatine, which is a melatonin receptor agonist. She was previously on hydrocodone, but she developed itchiness to this. So she stopped taking it by herself. Somehow this combination of neuromodulators work. So in addition to this, we actually added on Lyrica, and she was discharged with pain score of 3 to 4 out of 10. So she was last seen recently in April in our combined clinic. So she reported better control. So we were wondering whether this is because the neuromodulators are kicking in or whether the agomelatine is really working at this time. But she does have this hypervigilance where she really wants the pain to go away. Although she looks quite comfortable walking to the clinic, but she wasn't really satisfied with the fact that the pain doesn't really go away. But the baseline pain, she scored at about 3 to 4 out of 10. So this is some of the investigation that we did. So it's essentially normal except for a bit of elevated fecal calprotectin. CT is normal. We actually did a colonoscopy, which actually shows a bit of terminal ileitis. But one thing that I would like to highlight is the fact that the histology shows some element of hypereosinophilia. So we actually did sit down with our pathologist and asked whether this is actually hypereosinophilic colitis, but they didn't want to commit to that because they were quite convinced that the cutoff point for the eosinophil counts are not enough to label this patient as having hypereosinophilic colitis. But we do know nowadays that some element of hypereosinophilia in DGBI has been reported in a lot of studies. In fact, there's this meta-analysis that says that there is some element of elevated eosinophils in some patients of functional dyspepsias. So whether this is related to our patient or not, we are not too sure. So moving forward, what would be the best course of action? So we are trying to get this patient to be seen by our psychology colleague, but unfortunately, because of her recurrent abdominal pain, she wasn't seen for the past few months. So her appointment is actually due next month. Whether the neuromodulators are enough at the moment and whether we should be persisting with this or whether we should be tapering it off later on. Is there any other suggested non-pharmacological intervention? Whether the panel want to comment on the significance of eosinophilia on the colonic biopsies and whether the final diagnosis would be is agreed upon. So I do label this patient as centrally mediated abdominal pain syndrome as part of disorder of gut-brain interaction. And with that, I thank you.
Thanks, Hizami. So I'd like to ask in the same manner, maybe Andrew first. Do you want to give your comments?
Yeah, so thanks, Hizami, for presenting. I mean, it's an interesting case. We've had similar patients in the past, so I share with you some of my thoughts. When you see a patient who has this phenotype, that means they have IBS, diarrhea, they are atopic. That means they are very easily getting drug allergies, they have asthma, they have allergic rhinitis, and especially when you have eosinophils in your blood or in your biopsies, it gives you a suggestion that perhaps mast cells are involved, histamine is involved in the pathophysiology of their symptoms. Right? We don't know when their attack comes, whether there was a specific trigger. We don't know because it doesn't seem to be the case on the history. But usually what we try to do for these patients is you can consider doing a H1, H2 blockade. That means you give something like famotidine together with loratadine. You can try, if you have access to it, things like ketotifen, sodium chromoglycate, because when you stabilize the mast cells, you're more likely to settle the problem upstream rather than relying on H1, H2 blockade, because there are multiple histamine receptors, not just H1, H2, there's H3 and H4, right? So you need to try to figure out how to block them at a higher level. That's one. Tricyclics actually block histamine, right? They are anti-H1, but this patient, I'm a bit confused because the patient was struggling with insomnia. I mean, with insomnia firstly, then later on, the patient was excessively drowsy, right? As what you mentioned. So if the patient is excessively drowsy, I would keep. Usually, we prescribe our tricyclics in the evenings. We just do once a day. We don't give it twice a day, but you want to give it at night, because you want them to sleep it off, right? And if they are struggling with it because they are too drowsy in the morning, we try to do things like bringing it early. That means after dinner, they can already take the tricyclics. And actually, the drowsiness does wear off within 1 or 2 weeks. It's whether the patient can actually tide themselves through it. Because I see the patient is on multiple medications that make them drowsy. There's pregabalin, there's agomelatine, there is a tricyclic. So if I have a choice, I would choose one that has the highest chance of targeting multiple things, which is your tricyclics, because it has antihistamine and it's also non-adrenergic blockade. And so you want to use that drug and you want to build it up to a dose that you're comfortable with. So maybe you can get 50 milligrams at night and you stop everything else, you see. That's one strategy you can think about it. It's unfortunate that the patient also couldn't tolerate the rifaximin, because I think that would have been a drug that might have been useful for the patient as well, right? Also, when you are referring to a dietitian, don't just go for the low FODMAP. See whether you can change anything with a low histamine diet, because your shellfish, your chocolates, alcohol, things like that, they are high histamine, and they can actually trigger symptoms in someone who has conditions with mast cell destabilization, right? So I think those are some of the suggestions that I have for this patient.
Yeah, thanks, Andrew. Simon, your thoughts?
Thank you. Yeah, again, a really interesting presentation. In part, there wasn't so much about the psychological presentation, background history that I'd be really fascinated to sort of understand. From my understanding, there wasn't really high anxiety, although there was some hypervigilance. I guess one of the things that I really got from this was this journey of being well to then really being quite unwell and having to go on quite significant pain medications. And there has been some improvement, which is great, but there's a whole change to that person's life and experience, and it might be that that their pain, Andrew, you had that slide up that talked about sometimes when people are experiencing a pain, unfortunately, it might be part of their day-to-day experience, because pain is a human experience. And so I guess one of the things I'd be thinking about is, again, around exceptions, where they feel like they're managing it better, what's been helpful, but also in terms of what are the things that they are doing, what are they doing to maximize and move towards the things that they value? Because one of the things we know is that when we move to things that we value, it might be family, education, health, whatever it might be, as we move towards it, it means we build more resilience to manage some of the stresses that we have. And it might mean that maybe maybe she liked to run in the past, but now she can't run. But that doesn't necessarily mean she can't enjoy doing some other form of physical exercise. It might be walking, it might be other activities. So I guess one of the things that I'd be wanting to know is that her understanding of that history of her experience of symptoms, what's been helpful, and again, how do we get her to focus on what's important to her and how we can get her to move towards those things that bring meaning to her life.
Okay.
Right. Thanks, Simon and Andrew, for their thoughts. I don't see any comments in the chat. And again, I'm actually very mindful of the time so that we can have a good evening later on. You know, it's a Saturday after all. And being a first virtual meeting, hopefully we may want to organize a similar one in the near future. And I will be very glad to have Simon and Andrew again. Now, I'd like to also mention to everyone who are interested with what Simon is doing, do go over mindovergut.com and watch some of his YouTube video. I know that he has some YouTube videos as well. So with that, I'd like to thank everyone for your time today. And thank you to Malaysian Society of Gastroenterology, Hepatology, Yakut, and every one of you who have come to the meeting today. Thank you very much, everyone, and have a good evening.
Thank you.
Thank you very much.
Thank
Have a
you.
great evening.
Thank you.
Yakut factory in Seremban was established in the year 2004. Here, we produce a large supply of Yakut drinks throughout Malaysia. We also export Yakut Islite, which is the one with lesser amount of sugar, to Singapore. Our factory was awarded with Hazard Food Safety Certification in the year of 2006. As of now, we are producing 730,000 bottles of Yakut per day, and the maximum production capacity in this factory can reach up to 1 million bottles per day. Isn't it amazing? Let's head to the production gallery to see firsthand how Yakut is produced. This is the seed room. The mother bacteria that were imported from Japan needed to be awakened first in order to produce a lot of baby bacteria. Do you want to know where these bacteria live? They live inside the seed tank. Can you see the seed tank? Can't you please count with me? How many seed tanks are there? 1, 2, 3, and 4. Yes, you are correct. There are 4 seed tanks to keep the bacteria before they are transferred to the next room. Let's move to the next room. This room is the culture and mixing room. Here, we add skim milk powder, sugar, and water to make a milk solution inside these tanks. The milk solution is then heated up at high temperature to kill all bacteria. After that, the milk solution is cooled down, and then we add in the Yakut bacteria from the seed room earlier. The milk solution will turn into semi-solid like tofu fa after a few days. Lastly, the semi-solid solution will be pumped into storage tanks at low temperature where water is added to dilute the solution. Sugar and vitamins are added too to produce the unique taste of Yakut. Delicious Yakut drinks are now ready to be filled in the bottles. But where are the Yakut bottles? Aha! Here it is. This is where we make Yakut bottles. Yakut bottles are made from polystyrene granules. You can imagine the shape and size of granules are similar to rice. Surprisingly, 200 of these granules are needed to make one bottle. For each machine, it can make up to 14 bottles at a time, which adds up to 7,000 bottles in 1 hour. All these bottles are then transferred through a pipe over the ceiling using air vacuum and dropped into a bottle storage tank. And this room operates for 24 hours. Amazing, right? Now, let's go on to the next room. This is our clean room. Why do we call it a clean room? It is because this room is as clean as the surgical room. Microbiologists will check the conditions of Yakut bacteria here. Okay, that's all for the clean room. Next, here is where the quality and safety of Yakut drinks are checked and controlled. In this room, our staff constantly carry out a lot of tests so as to ensure Yakut drinks are in good quality and also taste delicious. These tests make sure you drink the best quality and most delicious Yakut. That's why this room is very important. Now, we are at the filling room. Yakut bottles are arranged nicely and the label is wrapped around each bottle. The bottles then enter the filler machine to be filled up with Yakut solution. After being filled, the bottles are closed immediately by aluminum caps. It takes only 1/10 of a second to fill and close the bottles. Did you notice that all the staff here are wearing clean uniform, hairnets, and safety boots? This shows that we pay strict attention on hygiene to avoid any contamination. Okay, let's move to the last area of the production. Now the bottles need to be packed. First, the bottles are packed into single packs or double packs. Single pack consists of 5 bottles, while the double pack consists of 10 bottles of Yakult. After that, the packs will be packed into 1 carton, which consists of 50 bottles, through the re-shrinking machine. Now, Yakult is ready to be kept in the cold room. The cold room is at the left side of this production room, behind the doors. Lastly, Yakult will be transported in chill conditions to the shops and distribution centers where you can purchase your Yakult.
Thank you, everyone. With that, I will end and I will close this meeting room. Remember to fill up the feedback form so that the MSGH can help to provide your CPD points for those who are collecting it. Thank you, everyone, and see you in our next iteration. Bye.